So today we have urologic and miscellaneous pathology, and Reza couldn't join us, so Christina is taking on a very heavy burden of presenting his cases as well as her own. And in the interest of time, so that just get started. Welcome, Christina, and pleased to hear what you're going to present. Okay.
So, before I start, probably you know that you have these evaluation forms on your tables. So please, I would ask you to fill this evaluations form because probably you know our meeting is accredited, so you will have you will get some credits. After you fill this evaluation form, we will change it for certificate. So please, in the coffee break, visit our registration desk, and they will exchange this form for your certificate. So thank you very much. Okay. So I'm going to present two cases which were originally contributed by Reza. Probably you know that Reza lived long time in Canada, in Vancouver. I think 3 years ago he moved to US, so now he's part of the GU team in the Cleveland clinic. But there is something significant in his personal history, and this is that originally he is from Iran. He was born and he grew up in Iran. And because the political situation in US is very complicated right now, so he discussed if it is good to leave the US right now with the lawyers, and lawyers didn't recommend him to leave the US. So this is the reason why Reza is not here with us. But we have his cases, and I will present it for you. So, case 42. This was a 54 years old man, which presented with 8 centimeter renal mass. There was nothing significant in the macroscopic appearance. The whole kidney tumors looks relatively in the same way. So we can skip directly to microscopy. So here you can see the tumor is from the spectrum of pink tumors of the kidney. Here you can see the tumor was arranged in nested and tubular architecture, and the tumor was composed from eosinophilic cells with finely granular cytoplasm, and from the first look you can appreciate that there are very severe irregularities of the nuclei with so-called resonant characteristics. You can see perinuclear clearing. Even very frequently there was binucleation or multinucleation of the cells. I told you that the tumor was arranged into tubular and glandular or microcystic fashion, as you can see here. Very frequent in this type of renal cell carcinoma, you can find these pigmentations, which can be intraluminal, and sometimes you can even find these beautiful calcifications, in this case sarcoma calcification. In other parts of the tumor, we found a little bit different morphologic appearance. You can see areas of fibrosis where the neoplastic cells are growing in tubular structure and nested structure on the fibrotic background, which can resemble the renal oncocytoma-like areas. So we have, I think, everything what we need for the diagnosis. We have the eosinophilic tumor, resonant characteristic, perinuclear clearing, we have binucleation. So this all is absolutely clear, and we can make the diagnosis from hematoxin causing slides. However, if you are not so experienced, probably you can employ some immunohistochemical stains. I recommend you 2 or 3 stains. Usually, please don't use white panel. Use only a very limited panel for this diagnosis. So the first one is CKIT. CKIT is typically positive in this entity, but please remember that the positivity may be weak and only focal. If you compare it with mast cells, which are normally present in the tumor, really the positivity, the intensity of the staining is weak. Then the second staining, which I can recommend you, is CT7. These tumors are typically diffusely positive for CT7. However, even in this tumor may be a heterogeneity in the staining pattern. As you can see here, you can see the part of the tumor which is diffusely positive, and then part of the tumor, which is in which the CT7 is reactive only in single cells, which resemble the staining pattern of CT17 for oncocytoma. Other staining which I use relatively frequently is vimentin. The vimentin is typically negative in this type of tumor. So the diagnosis is chromophobinous cell carcinoma. In this particular case, we have some special subvariant of this multicystic adenomatoid chromophobinous cell carcinoma. The first documented chromophobinous cell carcinoma was probably described by Masson in his French book, as you can see here. However, in this book, it was not labeled as chromophobinous cell carcinoma, but he labeled this tumor as hypernephroma or oncocytoma or something in this way. However, from the picture, we think that this was the first description, first documented case of chromophobinous cell carcinoma. The first cohort of chromophobinous cell carcinoma was described in 1985, and this is the description of chromophobinous cell carcinoma as we know it right now. We distinguish different subtypes of chromophobinous cell carcinoma. The most frequent variant is the classic variant of chromophobinous cell carcinoma. However, relatively frequently you can meet, for example, eosinophilic chromophobinous cell carcinoma. Very important is the diagnosis of sarcomatoid chromophobinous cell carcinoma, and then we have other rare variants of chromophobinous cell carcinoma. Most chromophobinous cell carcinoma occurs sporadically. Usually there is male predominance and the patients are typically older. However, a small part of chromophobinous cell carcinoma may be associated with hereditary conditions. The chromophobinous cell carcinoma you can find in a relatively wide range or wide spectrum of hereditary conditions such as Bioptická syndrome, tuberous sclerosis complex, or Cohen syndrome. Generally, chromophobinous cell carcinoma is regarded as a tumor with indolent or good prognosis. You can see that 10-year cancer-specific survival is about 87%. If the tumor has recurrences or metastasis, the prognosis of an overall survival is comparable with clear cell renal cell carcinoma. However, the incidence of the recurrences, metastasis, and death is relatively low in this entity. The prognosis of rare variants, because I told you that there is not only the chromophobinous cell carcinoma, the classic type, however we have some special subtypes of variants. So there is a little bit problem because the subvariants are relatively rare, so it is not easy to establish the prognosis of these tumors. However, it seems that the prognosis of these rare variants of chromophobinous cell carcinoma is comparable to those of non-sarcomatoid clear cell renal cell chromophobinous cell carcinoma. So the diagnosis. The diagnosis is fully based on the hepatoxin eosin slide and low magnification in the microscope. So you need to see eosinophilic tumor, rhizoid characteristics, binucleation, perinuclear clearance. This is enough for you. If you are not experienced, okay, you can use the limited panel of CD117, CT7, for example, vimentin. You should know that in CT7 there is a relatively wide range of reactivity. The classic chromophobinous cell carcinoma is usually diffusely CT7 positive. However, if you have, for example, eosinophilic variant of chromophobinous cell carcinoma, this tumor may be even completely negative for CT7, which can lead you to a wrong diagnosis towards renal oncocytoma. In limited samples, sometimes the diagnosis may be challenging. The key histologic features, along with pertinent immunohistochemical stains, can assist for the diagnosis. So, about the grading, probably you know that in the chromophobinous cell carcinoma we should not use the classic grading, nuclear grading, which we use for other renal cell carcinomas. It is because this gradient doesn't correlate with the prognosis of the disease. So it was shown in different studies that the most important adverse prognostic signs are presence of the necrosis and the sarcomatoid differentiation. So this is the reason why in every case of chromophobic cell carcinoma you have to make excessive sampling of the tumor to be sure that there is no necrosis, that there is no sarcomatoid differentiation in this particular patient. Here you can see some pictures. So this is a classic variant of chromophobic cell carcinoma. In the classic variant, you typically have mixture of bigger, more clearer cells together with smaller, more eosinophilic cells. Once again, very important, and the most important is rhizomatoid characteristic, perinuclear clearing, and denucleation of the cells. Sometimes these tumors can have very big autolysis, so in these cases the diagnosis is challenging. However, I recommend you to go back to the sample, to the material, sample the periphery of the tumor, and this usually helps you more than the excessive immunohistochemical examination. Here you can see that, or I already mentioned it, we have different subtypes of subvariants of chromophobic cell carcinoma. Very interesting, the majority of the variants and subtypes was described in our department by Ondra Hess. So this is work of Ondra Hess. We distinguish pigmented microcystic chromophobic cell carcinoma, chromophobic cell carcinoma with neuroendocrine or neuroendocrine-like feature. We distinguish papillary pattern chromophobic cell carcinoma. So there is a lot of different morphological patterns. And what is important, we tried to establish the prognosis of these patterns. So I think this is the last publication which Ondra wrote in 2022. And in this publication, we established that probably the prognosis of the variants is the same as non-sarcomatoid chromophobic cell carcinoma. Here you can see some examples. So this is multicystic chromophobic cell carcinoma, which probably is a spectrum of microcystic chromophobic cell carcinoma. You can see that again the tumor may be very cystically arranged, and sometimes it is not easy to establish the diagnosis because here you can see that the nuclei are relatively oval. However, if you are going through the tumor, you will find the typical areas with rhizomatoid characteristic, perinuclear clearing, and this is what makes the diagnosis. Here you can see another subtype of chromophobic cell carcinoma. This is chromophobic cell carcinoma with neuroendocrine line or neuroendocrine areas. These areas even stain with synaptophysin. So again, this is a pitfall. These cases with neuroendocrine areas were a little bit more aggressive than the classic chromophobic cell carcinoma, at least in our study. Here you can see the papillary architecture of chromophobic cell carcinoma, really with formation of papillas within fibrovascular cores. But again, you can see the multinucleation, perinuclear clearing, so the characteristic is typical for the chromophobic cell carcinoma. Here you can see small cell variant of chromophobic cell carcinoma with these areas of small cells, more pronounced here or here. You can see the sharp demarcation between the classic chromophobic cell carcinoma and small cell areas. Again, if you use the immunohistochemistry, it corresponds absolutely good with the chromophobic cell carcinoma. So this is only a variant of chromophobic cell carcinoma. Thank you very much. This is all.
Thank you very much for this very quick and succinct walkthrough of chromophobic. Questions and comments? Jonathan.
How did you interpret the heterogeneous nature? You talked about the almost one-like part.
Good question.
Oncocytoma-like part, to be honest, I think that in every renal cell carcinoma, which with oncocytic feature you can find the areas where the tumor is growing on the fibrotic background and form the nest. So it is relatively, I think, fragment even the architecture in the different renal tumors. So again, this is mixture of different morphologic sites which makes the diagnosis.
I can respond to that as well, because I used to do quite a lot of work with Onda, and we did a lot of immunohistochemistry, and it turns out that there's a lot of heterogeneity, and so those tables that you see in the books, yes, they apply very nicely to typical areas, in cases where you don't need it. Whenever you need it, you will get funny immunohistochemical outcomes, so those tables, that looks very nice and fair and square. Of course, they are helpful in a way, but they're also not helpful. They'll be very misleading if you're not aware of this very common heterogeneity because of the morphologic diversity. And also, when it comes to as you nicely pointed out, we always, when we're talking about chromophobe, emphasize, go and look at the nuclear morphology, and you find areas that are really typical, also heterogeneity, but you get the wrinkle, the racinoid nuclei, the halos, very nicely. Doesn't have to be too extensive, but it is there, and sampling is important. Yes, Johan?
I will celebrate now, and there we have the concept of carcinoma X. Very speculative.
Yes.
Okay. Anything else? Yeah, I think it's important to be aware of the textbook variant of immunohistochemistry for the venous. It's not only chromophobe, it's for a lot of yes, because it can be misleading. Okay, so if not, we move on to the next case will be presented by Dr. Salviato. The floor is yours.
Okay, now we start with 33 cases. 37. Okay. This was a 67 years old woman who underwent a partial stomach resection in July 2024 for a GIST. And the previous imaging in July 2024 saw in the CT scan a hypodense nodule in the posterior gastric wall. The nodule was 5.7 centimeter in diameter, and the tumor was growing inside the stomach close to the dorsal surface of the pancreas. And there was an absence of a clear cleavage plane between the tumor and the adjacent structures. After 1 year, a new CT scan revealed the right linear nodules located in the cortex, and it was 4.5 centimeter, and the nodule was imprinting the renal calyces. Treatment before was a renal nodulectomy, and this is the lesion. It was a smooth nodule measuring 4.5 centimeter in maximum diameter with a hemorrhagic surface. Histological was a stromal proliferation composed of round cells arranged in solid nests. Some cells exhibit clear cytoplasm, branching blood vessels, and the areas of hemorrhage were observed. And the tumor was largely well circumscribed by a fibrous capsule that separates from the normal kidney. Here you can see the fibrous capsule that well separated the lesion from the normal renal parenchyma. We performed a large panel of antibodies, and to further support our microscopic findings, because we had an idea, but as always, the man of Istanbul is under. And the case was submitted for a second opinion to Professor Abbas Agaimi, who kindly performed additional staining at his institution. So the lesion was positive for SMA, collagen 4, BCL2, cyclin D1, and vimentin, while it was negative for keratin, ALK, MAC4, NAT, TFA3, CK20 and CK7, CD10, FAX8, synaptophysin, KITES, KIT, Desmin, S100, HME45, STAT6, racemase, DOP1, chromogranin, HHV8, CD34 and CD31, CD99, podoplanin, BRAF, melanase CD65, and SDHB was retained and advertised. So we can see SMA positivity, the cellular well were all positive, all BCL2 are positive, and biomentin, cyclin D1. So the diagnosis was glomus tumor of kidney. Professor advised regular follow-up since this tumor may recur locally or rarely metastasize. There were no evidence of CDHB-associated RCC or extraglomerular cell tumor, so he ordered molecular fusion testing as followed. And it was initiated using a small DNA NJs panel from Qiagen, and the panel includes 30 cancer-related genes, notably the RAS gene family, and test results showed no pathogenic variants in any of the 30 genes. Therefore, the molecular background of this atypical glomus tumor of the kidney remains unclear. Glomus tumors are composed of three main components, as everybody knows: glomus cell, blood vessels, and most muscle cells. Glomus cells, they are small, uniform, round to oval cells with distinct cell border, centrally located punch-out nuclei, and like eosinophilic to amphophilic cytoplasm. Blood vessels that are usually thin-walled, capillary-sized, dilated or branching, and smooth muscle cells, elongated mature-appearing cell. So, we have some predictors of aggressivity of the behavior that are typical mitotic figure, moderate to high nuclear atypia, and more than 5 mitotic figures at high power 5. And the glomus tumor of a certain malignant potential does not meet the full criteria for malignancy, but presents at least one atypical feature other than nuclear pleomorphism, measured than more than 2 centimeters and more deeply located. So, of course, glomus tumor are rare mesenchymal neoplasm originating from the neuroarterial glomus, and skin structures involved in temperature regulation, and they represent less than 2% of all soft tissue tumor, and they are most commonly seen in young adults. This is not our case. And typical representation includes painful nodules in area-reaching glomus bodies at subungual region, palm, wrist, forearm, and foot, and this is not our location. And the term glomus tumors were first introduced by Masson in 1924. Renal glomus tumors are extremely rare and may be mistaken for renal cell carcinoma. Definite diagnosis is made by histopathological examination, and no standardized treatment guidelines exist due to the rarity. However, surgical resection is a preferred approach. So, differential diagnosis is with myopericytoma, that is made by pericytic perivascular tumor, blunt myeloid appearing, spindle cell with concentric perivascular growth, and may have BDGFRB mutation. Or with extraglomerular cell tumor, but generally they are young patients with severe hypertension, hypokalemia, and elevated plasma renin. And they have overlapping features with glomus tumor on light microscope, but KIT expression is present in more than 50% of cases, and also they have renin crystals that we can see on electron microscopy. Paraganglioma, but sustentacular cells are positive for S100, chief cells are positive for neuroendocrine markers, that is not our case, and they are negative for cytokeratin, SMA, and collagen 4, what we had in our cancer. Well-differentiated neuroendocrine tumor that are NES, organoid architecture, plasmacytoid cells with stippled chromatin, but they are positive for cytokeratin and neuroendocrine markers, and are negative for SMA and collagen 4. And solitary fibrous tumor that is positive for STAT6, and we have a fibroblastic spindle cell tumor with patternless pattern and Sagan-like vasculature. Angiomyolipoma is another different diagnosis, but it is three-phasic tumor with mature adipose tissues, muscle, and thick wall vessel. And they are positive for melanocytic marker and SMA calponin and catepsin K. So, in conclusion, renal ramus tumor is a rare neoplasm with non-specific clinical symptoms. Diagnosis is based on histopathological examination and indistinguishable from other renal tumor using imaging or laboratory data. And there are not established guidelines for treatment, but the prognosis is generally favorable. Surgical resection remains the primary therapeutic option regardless of a tibia level. And of course, this is Naples, and this is the veil Christ that is a must if you go to Naples to see. And thank you.
Thank you so much. Very nice case and very nice succinct discussion of the differentials. Questions and comments pertaining to this case?
Is there a malignant equivalent?
Yeah, in our case, no, but yes,
in general.
Yes, in general, yes. There is.
How do they sign it out?
Ramus tumor, and we put also the diagnosis of Professor Abbas just to confirm our diagnosis.
There is a malignant there.
Yeah.
There are criteria.
Yes, the mitosis, the necrosis, and
regarding the question on malignancy, they are quite good defined. It occurs as a soft tissue lesion. There's a nice paper in AGSP maybe 2 years ago on gastric cases because it's the organ where it very frequently occurs. Size, mitotics, atypia, etc. And there are some borderline cases. And in these cases, you can use molecular. You can do copy number variation analysis, and if it's flat, it's probably benign. If it's like this, it's probably going to be aggressive.
Okay, good to know. Very good to know. A few months ago, we had a myxoid variant of renal glomerular tumor, which kind of was confusing the picture. So we did the same as you did. We were kind of certain on the diagnosis based on SMA and so on and so forth. But we were concerned about they are so rare, so we sent to Abbas as well because we wanted to exclude just the glomerular cell tumor. But it was a mixed variant group. Excellent. Okay. Any more questions, comments? If not, thank you so much. And then I think it's the superwoman again coming.
Okay, so other renal case, again from Reza, so case number 44. So this was a 65 years old lady which presented with the 4 centimeter renal mass. As you can see here, for low magnification, the tumor was sharply demarcating, reaching the resection margin, but the tumor was without any catch. Here you can see that again it is from spectrum of pink renal tumors. You can see that there is a solid component, solid area, and this area is merging with the central loose myxoid areas. Not only edematous area was very present in this case, however, even hemorrhagic area was noted. Here you can see the high magnification of the solid area. You can see compact solid nests which I form, which contains the cells with finely granular eosinophilic cytoplasm. Please. Probably you can appreciate that the nuclei were oval to round and that there was no irregularities, but you can see the perinuclear clearing in these cells. If we move to edematous area, you can see that there is a characteristic pattern of growth for this tumor, and you can see these elongated trabecules and bands. You can see that on the edematous area you see solitary cells, and probably again you can think about the renal-oncocytoma because in the renal-oncocytoma there are areas, typical areas, when you have the loosely connective stroma, loosely connective background, and on this background you can see the growth of the cells, eosinophilic cells. However, in renal-oncocytoma the pattern of growth is a little bit different. In renal-oncocytoma you see tubular structures, nested architecture. However, here you can see something which we call bolts in way. And this is absolutely the most characteristic pattern of growth for this tumor. Here you can see the hemorrhagic area. Again, there are trabecules, there are not nested architecture nor tubular structures. Again, one detail for a hemorrhagic area. And I think, again, this tumor the diagnosis is made from hematoxin eosin slides. However, again, we can use some limited immunohistochemical panel. So here you can see CD117, which is completely negative. You can see the positive internal control in the mast cells. Then you can see C7 positivity, diffuse positivity, which is characteristic for this tumor. And from new marker, GATA3 positivity, I think GATA3 is a very good marker. However, it has relatively low specificity for this tumor. The sensitivity is fine, but the specificity is low. And from newer markers, you can use GPNNB, which is typically positive in these cases. So the diagnosis is low-grade oncocytic tumor, abbreviation LOT. Probably you know that the spectrum of eosinophilic tumor, pink tumors of the kidney is very wide. On one end of the spectrum there is renal-oncocytoma, and on the other end there is chromophobia cell carcinoma. And between there is a lot of tumors with overlapping morphology, mixed morphology, or morphology which we are not able to which morphology which doesn't fit in any of these established entities. And from this in-between category, we generated in past a few well-known entities. For example, eosinophilic solid and cystic renal cell carcinoma, low-grade oncocytic tumor, eosinophilic maculated tumor. By the way, all these tumors were described by my colleague Andreas. I told you that the cases in between may share the morphology. Sometimes so. Ondra Kirill note that there are cases which share the oncocytoma-like areas and which are merging with some chromophobe-like signs, such as perinuclear clearing, and collected a cohort of this tumor and stained it with the same immunohistochemical panel. And after staining and morphologic analysis, they were able to present these cases as an entity, which typically has diffuse CT7 positivity and CD170 negativity, and they called these tumors low-grade oncocytic tumor of the kidney. Low-grade oncocytic tumor of the kidney is right now the WHO provisional entity. It was because the first publication about LOT was published in 2019, so there was no so deep evidence about this entity when the WHO classification was created. So it is only a provisional entity in this in current WHO classification, but we hope that in the next WHO classification it will be a separate entity. The incidence of this tumor is unknown. However, we estimate that it is about 4% of oncocytic renal neoplasms. If you are in a routine GU surveys, you can have a few cases in 1 year, so this is not a rare neoplasm. The tumor has a relatively broad age range, more females. Usually the tumor is solitary, however, some multifocal cases were described, and the tumor is usually small. Mostly the tumor is present in sporadic settings, however, again, there can be a hereditary association, mainly with TSC complex syndrome. Today, no aggressive behavior was reported in this tumor. Here you can see the typical macroscopic appearance from the publication with Kirill. You can see that it looks absolutely in the same way as others. Oncocytic tumor of the kidney, some scary area, mahogany, tan yellow, brown cut surface. So there is nothing special from the macroscopic point of view. If you use the immunohistochemistry, so most significant is the diffuse positivity of CT7, which is in the opposite to rhinooncocytoma, which is typically CT7 negative. And on the other hand, negativity of CD117. From other markers, you can use GATA-free, once again, relatively high sensitivity but low specificity, and from newer markers, GPNB helps, I think. Here you can see the publications about the LOT. From the beginning, when we have only the morphologic description and immunohistochemical profile, now we have a lot of publications dealing with the molecular genetic background. It was shown that the majority of cases is alterated in mTOR and TSC pathway. Some of cases had deletions of chromosome 19 and 1p. Differential diagnosis of this tumor, so I think it's relatively easy. So chromophobia cell carcinoma, mainly the eosinophilic variant, rhinooncocytoma, and SDHB deficient renal cell carcinoma. So chromophobia cell carcinoma share with the eosinophilic morphology and perinuclear clearing. However, in chromophobia cell carcinoma, you should see more prominent membranes, irregular nuclei, and binucleation, which is not typically present in LOT. From the immunohistochemical point of view, LOT is negative for CD117, chromophobia cell carcinoma is positive. Other entity in differential diagnosis is oncocytoma, so I spoke about it. Here you can see the typical growth of oncocytoma on the fibrotic or edematous background. Oncocytoma forms the nested and tubular architecture, however, lots form the bolts in the way. Again, the immunohistochemistry is in opposition. Oncocytoma is typically CD117 positive, and CT7 negative, or the CT7 positivity is only in scattered cells in the fibrotic areas. However, ROT is diffusely positive for CT7 and negative for CD117. The last entity in the differential diagnosis is SDHB. It is not last, but in the main differential diagnosis is SDHB deficient renal cell carcinoma. The morphology of the cytoplasm is a little bit different in these two tumors. However, again, it is in the pink group. If you need help, so please use the immunohistochemistry. SDHB is typically negative. In SDHB deficient renal cell carcinoma, however, please remember that the SDHB there can be only a decrease of intensity of SDHB in the tumor. So it is better to search for a block where you have the non-neoplastic parenchyma together with the tumor to stain this block, because in the SDHB evaluation you should evaluate the intensity of the staining, and only the decrease of the staining is enough to label this tumor as SDHB negative, and you have to confirm it by molecular genetic testing. Practical points. LOT is hematoxylin eosine diagnosis with a limited panel of immunohistochemistry. If you have a multiple loss, probably you should think about some hereditary condition. Because no aggressive behavior was reported in this tumor, so do not use ISUP or W2 grading. It is a good question if we can make the diagnosis of LOT on core biopsy. If you are not absolutely sure, we recommend to use the vague term oncocytic renal neoplasm of low malignant potential with comment that probably after the immunohistochemistry there is high possibility that it can be only LOT. However, you are not absolutely sure. And here you can see the example how Reza reported the cases of lots. So low-grade oncocytic tumor, tumor confined to the kidney, and surgical margins are free of the tumor. With the comment, to date, limited data indicated lots tends to follow an indolent behavior. Thank you very much, and this is all from Reza.
Thank you very much for that presentation as well. Questions, comments? I think that loss is one of the reasons that we do perform immunohistochemistry, especially in relation to chromophore, because this is most likely totally benign, but there is small risk of malignant behavior in conventional chromophore. And it's helpful. Anything else? Yeah.
Do you think this is same as the hybrid tumor?
It's not, because hybrid tumor, according to WHO classification and GAPS recommendation, hybrid tumor, the name, the label, hybrid tumors, hot, should be used only for cases which are associated with hereditary conditions. So only in hereditary conditions you can use the name hot.
A very good question. No? It's based on just morphology, it's a murky area, but that is clarified by the reply by you. Anything else? If not, well.
Okay, so I will skip to my cases. So we will change the spectrum, we will stay in kidney, however, my first tumor will be a little bit different. 43 years old man, which presented with renal mass. The patient underwent a partial resection of the kidney, and the tumor was removed, no specific in macroscopic appearance, and the largest diameter was 2.2 centimeters. Here you can see the overview of the slide. You can see that the tumor is relatively sharply demarcated, and probably in the periphery, I think you can appreciate that there is something which looks like capsule, which is formed from muscular cords. The tumor is partially cystic, as you can see here. In high magnification, you can see that it is composed from cells with abundant clear cytoplasm. The tumor was arranged in tubulo-papillary pattern with some areas which resembled the classic pattern of clear cell renal carcinoma. However, you can note that in between these cells, in between these acinar structures, you can find muscular bundles, and it is in the whole. It is a component of the whole tumor. Here you can see more papillary areas of the tumor with thin fibrovascular cords, which are lined by the cells, clear cells, with a relatively low nuclear grade. The nuclei are irregular, however, they are not prominent nucleoli. Again, there is more accented fibromuscular part of the tumor. There is cystic area, and this is a typical appearance. So from the first look, you know that this is clear cell spectrum of renal cell carcinomas. However, it is not absolutely typical morphology for clear cell renal cell carcinoma. So probably you should employ some immunohistochemistry. So pancytokeratin diffuse positive, carbon anhydrase diffuse positive in box-like distribution. AMR, it is positive, but weakly positive if you compare it with the non-neoplastic parenchyma in the periphery. And then very important staining CK7, which is diffusely positive in this tumor. So from this morphology and immunoprofile, so you should go for the genetic testing. So I ordered the NGS testing through site 500, and there was a result. There was a mutation in ALOT gene. So, oh yes, probably I have something. So, can I make the diagnosis of ALOT mutated renal cell carcinoma? I'm not sure. So I went back to WHO classification and analyzed my case and compared it with the criteria in WHO classification. So from the WHO classification, we know that alloc-mutated renal cell carcinoma harbor mutation in alloc gene. The neoplasm had a nodular appearance at low power created by thick transecting fibromuscular bands. The architecture is that of branching infolding tubules and well-formed papilla. The neoplastic cells are low-grade with voluminous clear cytoplasm and prominent cell borders. In the absence of nuclear inverse polarization, very important. The neoplastic cells are immunoreactive for CT7 with relatively high variability, ranging from patchy to diffuse. Carbohydrate 9 is typically complete membranous, and these tumors are typically CD10 positive. A demonstration of alloc mutation is required to definitively diagnose this neoplasm, and the essential and desirable diagnostic criteria according to WHO classification is demonstration of alloc mutation, which is required to definitely diagnose this neoplasm. So, okay, probably I have alloc mutated renal cell carcinoma. Yes, this is very rare, so super exciting. The alloc-mutated renal cell carcinoma was first time introduced in WHO classification in 2022. It is a part of molecular defined renal cell carcinomas. And the first publication about alloc-mutated renal cell carcinoma is 2013 in this publication. And in time when the tumor was included in WHO classification, only 20 cases were documented in the literature. So the knowledge about this tumor was not so deep. And I think that this was not a good decision to include this tumor in the WHO classification if you have only 20 cases documented in the literature. Once again, in this time, the essential and desirable diagnostic criteria was the presence of alloc mutation. After the WHO classification in 2022, a first publication was published describing alloc-mutated renal cell carcinoma. The diagnostic criterion was presence of alloc mutation. Point mutation of alloc gene was detected by scientific sequencing. This cohort of alloc-mutated renal cell carcinoma absolutely correlated with the WHO description, so it was fine. However, in 2023, in Modern Pathology, Holger Mock and his colleagues described or published this publication, and he found 17 tumors, alloc-mutated tumors in the literature, and showed that all these tumors have biallelic inactivation of alloc gene. So not only mutation, but probably biallelic inactivation of the gene have to be present to cause the tumor alloc-mutated renal cell carcinoma. Why it is important? Because even in alloc-mutated renal cell carcinoma, you can find the molecular genetic characteristics which are typical for clear cell renal cell carcinoma. And if you have the molecular genetic characteristic of both tumors, so how to call it? So probably only cases with biallelic inactivation of ELOC gene can be called ELOC-mutated renal cell carcinoma. And the next publication showed that if you have a case of biallelic inactivation of ELOC gene and there is concurrent presence of UHL mutation or abnormality, it means that this tumor probably will be aggressive because the original alloc-mutated renal cell carcinomas are indolent. However, the aggressive alloc-mutated renal cell carcinoma, which UHL abnormality, are very aggressive. So this is very recent paper from Modern Pathology. It is in press right now, and this group concluded that it is not uncommon to observe monoallelic loss in clear cell renal cell carcinoma and monoallelic UHL copy loss in alloc cases. Notably, within alloc renal cell carcinomas cohort, we observed that monoallelic UHL copy loss was frequently observed in advanced stage of allogeneic renal cell carcinoma, occurring as either an early or late event in tumor progression. And this suggests a potential role of UHL loss in allogeneic progression. So now this question, what should we call as ELOC? Mutated renal cell carcinoma, if it is the ELOC, only the ELOC mutation which drives the diagnosis, or if you have to have big allelic inactivation of ELOC to call the tumor ELOC mutated renal cell carcinoma. Okay, so according to WHO classification, my case is ELOC mutated renal cell carcinoma. In the differential diagnosis, there are four cases or four tumors in the differential diagnosis. The first one, or three tumors in the differential diagnosis. The first one is renal cell carcinoma with fibromyalgia stroma. The second one is clear cell papillary cell carcinoma, clear cell papillary renal cell tumor, and the last one is clear cell renal cell carcinoma. So now, renal cell carcinoma with fibromyalgia stroma. These are tumors which are typically composed from clear cells which are arranged into tubular fashion and has prominent fibromuscular component. These tumors are typically positive for CP7, typically both slight positivity of carbohydrates and AMR, so there is overlapping morphology with allogeneic mutated renal cell carcinoma. However, the molecular genetic background of this tumor is different. These tumors typically don't have the allogeneic mutation, however, they typically are characterized by alteration in mTOR and TSC1 pathway. These tumors are described as indolent. So this is the reason why it's very important to distinguish this tumor from clear cell renal cell carcinoma. Other tumor in the differential diagnosis is clear cell papillary renal tumor. Originally, this tumor was described by Michael as angiomyoadenomatous tumor. It is indolent tumor composed from cuboidal and low columnar cells with a small nuclei histologic grade 1 or 2. These nuclei are only oriented towards the luminal aspect of the cells, and the arrangement of the tumor is typically cystic, tubulary, tubulopapillary. They may be presence of fibromatous stroma component. The tumor typically lack any abnormality, genetic abnormality, so there is no UHL abnormality, there is no mutation of UHL, TSC1, TSC2, mTOR, or alloc. Again, there is overlapping immunohistochemical profile. CT7 positive, there is so-called CAP-like positivity or carbohydrates. These tumors are typically positive for GATA3. Here you can see the picture of the tumor. So this tumor with relatively prominent fibromuscular stroma. You can appreciate the elevation of the nuclei from the basal membrane. And here you can see the typical immunohistochemical profile. Carbohydrates should be positive in so-called CAP-like distribution, and the CT7 is diffusely positive. Once again, there are no genetic abnormalities in this tumor. And the last tumor in the differential diagnosis is classical clear cell renal cell carcinoma, which may have some muscular component in the stroma. Tumors are typically carbohydrates 9 positive. Usually or typically, clear cell carcinoma should be CT7 negative, but we know that CT7 reactivity may be known even in clear cell cell carcinoma, especially in low-grade clear cell cell carcinomas. The positivity of CT7 may be relatively strong and diffuse. For the diagnosis, if you need it, you can use it. UHL abnormalities, methylation of UHL, or deletion of 3P is typical for a clear cell renal cell carcinoma. Here you can see a case with prominent fibromuscular bands. You can see that this is clear cell tumor, again arranged in papillary fashion. You see the stroma stromal component, the nuclear grade is a little bit higher. You can see irregularities, however, there are not prominent nuclei. CE7 is focally positive, so there is overlap with our entity. However, I made the molecular genetic testing because of the morphology and immunohistochemical profile, and we revealed the mutation of UHL, and we revealed the deletion of 3P. So this is renal cell carcinoma, Pilsen renal cell carcinoma, and not the TSC1 or 2 or mTOR mutated renal cell carcinoma with fibromyalgia or LO mutated renal cell carcinoma. So what is important? Clear cell cytoplasm, variable tubulo-papillary architecture, prominent stroma, and overlap with CT7 and carbohydrate expression can be present in the clear cell renal cell carcinoma, clear cell papillary tumor, renal cell carcinoma with fibromyalgia and ELOC mutated renal cell carcinoma. The presence of leiomyomatostroma is deemed to be unspecific for a particular entity of renal cell carcinoma, and all the characteristic morphology and immunohistochemical profile helps identify potential ELOC cases. These features often overlap with other tumors. So thank you very much.
Question comments for this kind of difficult area. I have one question. So this area of mutated RCC, how to deal with them? Should we send all funny clear cell RCC-like tumors for ELOC mutation?
To be honest, we are in this way right now because, this ELOC is in the majority of cases indolent tumor.
Yes, that's why it's important.
Yes, so this is the reason why it is important. And as clear cell carcinoma, you should label only tumors where the morphology is absolutely clear. Where you are able to find areas which are typical for clear cell carcinoma. And if you have some problem, there is abnormal immunohistochemical profile, the morphology doesn't fit very well. It is better to send it for molecular genetic testing because it is very significant for the patient.
Yes.
Because clear cell carcinoma right now is treated in a different way than others.
Yes.
We have the treatment for clear cell carcinomas, but we don't have the treatment for non-clear cell carcinoma. So this is the reason why it's very important to distinguish between clear cell carcinoma and other tumors.
Yes, and most likely then more cases of ELOC mutated RCCs will be documented. So kind of liberal use of ELOC mutation analysis for funny clear cell appearing tumors. You screen with broad spectrum cytokeratins. That's how I do it, because if it's very low or negative, then you go on a sort of translocation pathway. But if you get the next is a comment, and because we published quite a number of years ago in a series of clear cell RCC with red light areas. So you can have in low grade conventional clear cell RCC areas that very much look like clear cell papillary renal cell tumor. And those tend to be immuno-wise, they also a little bit rat-like, you see, right? So on core biopsy, you have to be careful. So there are cases in clear cell RCC, low grade most of the time, with rat-like and called a rat. Yeah,
Yes, it's fine.
Yeah, that's fine.
Here it is fine.
Easy. Yeah.
We are in the Bioptická, so here you're fine.
Okay. Yes, Ivan. Be patient.
Okay. How many cases are there altogether?
This publication, the last publication I had in the presentation, this is from I think May 2025, and they in literature there is 40 cases right now.
Okay. Are there any malignant?
Two cases very aggressive in the behavior. Above the cases has the UHL abnormalities together with the LO mutation and LO.
Did these 2 cases or 3 cases differ from the rest of the cohort?
Yes, a little bit. In one case, they noted that there was high-grade morphology, at least focally, and both these cases had necrosis.
Okay, thank you.
More questions, comments? If not, thank you very much. And then I think the next speaker is Dr. Michalová. This will be something strange, most likely.
Good morning, everyone. Thank you, Fred, for the introduction. It won't be a very strange case. It will be rather normal one. So I'll be presenting case 46, which occurred in 56-year-old patient. It was tumor of right testis, measuring 3 centimeters in the largest dimension, and the patient developed metastasis to retroperitoneal lymph nodes 22 months after orchidectomy. From the low power, you can appreciate the nodular architecture of the tumor and also quite extensive tumoral necrosis visible even in this low power. This is a different section or different block of the tumor where it is almost completely necrotic. Nevertheless, there were no infiltration into surrounding structure. The tumor was well circumscribed. There was no lymphovascular invasion observed. If we go to higher magnification and look into the viable areas of the tumor, we can appreciate that there were large atypical polygonal eosinophilic cells, with quite pleomorphic nuclei, hyperchromatic nuclei, and also quite abundant eosinophilic cytoplasm in the tumoral cells. This is more or less the same review of the viable part together with tumoral necrosis on the right hand side of the picture. There was also quite brisk mitotic activity going up to 8 mitosis per 10 high power fields. Immunoprofile of this tumor, there was a diffuse positivity for SF1 and a little bit weaker positivity for inhibin, but also diffuse, the pretty much same positivity for calretinin and also positivity for broad spectrum cytokeratins. We also performed another immunohistochemical stains, which were rather important for assessing the biological behavior of the tumor, which I will explain later. MDM2 was negative, and a staining of fumarate hydratase was retained. We also performed next generation sequencing with no positive results. There were no gene mutations, no fusion transcripts, and no significant copy number alterations detected in this tumor. But given the fact that the morphology was quite fitting and also immunoprofile was consistent with sex-scored stromal tumor origin, we labeled this tumor lytic cell tumor from the malignant spectrum of these tumors. Malignant sex-scored gonadal stromal tumors represent approximately 10% of the cases from all sex-scored gonadal stromal tumors, and these cases are quite problematic, all of them, given the fact that it is currently not possible to reliably determine biological behavior or prognosis if we look solely on histopathological features. There are for certain clearly benign and clearly malignant tumors which behave according to their histopathological features. But there is also a relatively large percent of the cases which harbor not unequivocal benign appearance, and yet there are no definitive signs of malignancy. So in such cases, it is currently often impossible to assess prognosis and definitive decision if the tumor is benign or malignant depends on actual biological behavior of the tumor, in other words, in the presence or absence of metastatic spread beyond the testis. And in rare cases, but it happens as well, the tumors can appear entirely benign from the pathological point of view, and despite this fact they can metastasize, or conversely, there are morphologically malignant tumors which can behave indolently. Going back to Leydig cell tumor, the malignant Leydig cell tumors, they represent approximately 10% of Leydig cell tumors. So its incidence, their incidence is similar to the scleroderma tumors in general, the malignant spectrum. And the malignant cases in Leydig cell tumors are restricted to adult population. These tumors can also occur in pediatric population, but seemingly these are different tumors which are reliably benign with different molecular backgrounds. So malignant cases are restricted only to adult population and tend to occur in elderly patient with average years of with average age of 60 years. And because of this problematic assessing the biological behavior of these tumors, there were earlier studies which attempted to identify malignant cases through histopathological characteristics. And in this red rectangle, we can see what are now currently established predictors of a potential aggressive curves of Leydig cell tumors. So it is a large tumor size, more than 5 centimeters, presence of marked cytological atypia, presence of infiltrative growth, tumor necrosis, lymphovascular invasion, mitotic activity more than 3 mitosis per 10 high power fields, and the presence of atypical mitotic activity, atypical mitosis. And according to these factors, the tumors which present with more than 2 aggressive histological features can be labeled as aggressive Leydig cell tumors, which also happened in our case because our case had marked cytological atypia, had extensive tumor necrosis, and had high mitotic activity. So it presented with three predictors of potentially aggressive behavior. But as I said before, it is not always the case that the tumor is histopathologically aggressive and that it behaves accordingly. So given this problematic aspect of estimating the biological behavior of sex cross-stromal tumors in general, this system was proven to be unreliable for Leydig cell tumors. So recently there are some attempts to create better systems which better predict metastatic risk of Leydig cell tumors. And these systems are multiparametric and try to be similar to those used for adrenocortical tumors. One of them was proposed by Fankhauser and colleagues, and the system is derived from data coming from meta-analysis, and these authors established some factors which were, according to their observations, associated with a higher risk of metastatic spread. And it is age more than 42 years, tumor size more than 3 centimeters, and the presence of unfavorable histological features, which are the same as the traditionally accepted adverse histopathological features. And they also established some protective factors, which were, according to them, associated with a lower risk of metastatic spread or aggressive behavior. And it is the presence of some symptoms of gynecomastia. And histologically, we found Reinke crystals or lipofuscin pigment. It also seemed to be associated with a lower risk of metastasis. So the simplified conclusion from this multiparametric system is that we can consider Leydig cell tumor as reliably benign or with a low risk of metastatic spread. Those tumors which lacked all unfavorable clinical pathological findings, or alternatively the tumors which exhibit only one unfavorable finding and concurrently present with protective factors. The main strength of this system proposed by Funkhauser is an integration of clinical factors into the assessment, so to get clinical factors together with histopathological features, and also the fact that this system was based on meta-analysis which encompassed large data encompassing over 1,300 patients. But there is a quite significant drawback that if we count unfavorable histopathological features, it was assessed as a single variable which artificially homogenizes their prognostic significance, because according to our experiences, these are not all of them at the same level. For example, if the tumor presents with extensive lymphovascular invasion and tumor necrosis, for example, as we saw in our case, this is more concerning feature than, for example, if the tumor has borderline atypia or slightly increased mitotic activity. For example, if there are 4 mitosis paired and high power fields, it's not so concerning as extensive lymphovascular invasion. So there were other attempts for this multiparametric systems, and the other system was proposed by Maurizio Colecchia and colleagues, and they approached it differently. They also had a multiparametric system, and they proposed to score mitosis, tumor size, presence of invasive growth and necrosis, and they suggested to put 0 to 2 points or to 1 point per every present adverse histopathological or clinical factor, and then from the complete score you can assess the potential biological behavior. The limitation of this system is that it was based on just a retrospective comparison of metastasizing and non-metastasizing cases, and also the fact that it does not include patient's age, which seems to be quite a significant aspect regarding the assessment of biological behavior. But taken together, both these multiparametric systems can help to improve risk stratification in patients with Leydig cell tumors when we compare it to the traditional system and counting only histological features. And also with minor modifications, this system can be used not only for Leydig cell tumors but also in other testicular sex cord-stromal tumors. What can be concluded from both studies is that the traditional 5 centimeter threshold is probably unsuitable, and that smaller tumors tend to behave aggressively. So the range of 2.5 centimeters to 3 centimeters seems to be more reliable. And certainly there are also other attempts to somehow distinguish benign and malignant Leydig cell tumors, and it is a molecular point of view. Recently, it has been shown that amplification of MDM2 gene, FH inactivation, TER gene fusions, and chromosome imbalance are connected or are linked to Leydig cell tumors which present with metastasis or are histologically aggressive primary Leydig cell tumors. And the good thing for routine practice is that some of these alterations, namely FH deficiency and MDM2 amplifications, can be assessed also immunohistochemically. We performed methylation analysis. This is so far unpublished data. It is our multi-institutional study. We have 28 malignant Leydig cell tumors, which we compared with benign cases, and we also included other entities. And these are the results, which are a little bit which are not clear, because you can see that from the epigenetical point of view, there is no single cluster pointing out the fact that there is some well-defined group and consistent group of cases. So according to epigenetic features methylation analysis, we cannot distinguish not only between particular subgroups of malignant Leydig cell tumors, for example, we also included FH deficient malignant Leydig cell tumors, but we also cannot distinguish from the epigenetical point of view between benign and malignant cases. So the epigenetic features, according to our observations, cannot be used to differentiate between benign and malignant cases. So in summary, Leydig cell tumors in approximately 10% of cases can behave aggressively. Currently, it is not possible to reliably determine biological behavior. Traditional factors, histopathological features, proved unreliable for assessing the biological behavior of Leydig cell tumor. Recently proposed multiparametric systems, which are similar to those used for adrenocortical tumors, can help improve risk stratification, and also recently there seems to be some molecular stratification between benign and malignant Leydig cell tumors, namely that the malignant cases more frequently bear MDM2 gene amplification, FH inactivation, TER gene fusion, and chromosomal imbalance. But it is not also absolutely true, because, for example, our case was overtly malignant from the histological point of view, but it was molecularly silent. It didn't have any of these features. And regarding methylation analysis, we currently, or at least in this current study, we didn't detect any epigenetic differences between benign and malignant cases. And that's all I have. Thank you very much.
Thank you for that update, very detailed update on these rare tumors. I mean, given the rarity of testicular sex-called tumors, I think it's good for us mortals to gang up with somebody, some friend or some colleague in a larger center, because especially given sort of the dynamics of the assessment of malignancy and for that. Okay, we have time for, it's only half day, so we have time for questions and comments. Paul?
Of course, this is out of my field of knowledge, but when you say these patients behave aggressively, where do these metastasize? Question number one, where do these metastasize to other than lymph nodes? And number two, do patients actually die from aggressive disease?
Preferentially, most of these tumors metastasize into retroperitoneal lymph nodes, and if there is metastasis outside the lymph nodes, it's preferentially to the lungs.
Yeah, that's a tricky diagnostic situation if you have an unknown primary and you encounter this first as a metastasis. I mean, to trickle down to the testicular origin, that's not easy. Okay, was that on this?
Regarding methylation analysis, disappointing results. Could it be considered that either using sarcoma classifier or brain tumor classifier in methylation analysis might be the obstacle, as well, sexual tumors do not exactly fit into either of those?
We didn't use any of those classifiers. We derived the data from the particular cases we had, and did the methylation analysis by comparing each tumor entities with each other. We didn't use the official classifiers for these tumors.
So it was very DIY, do-it-yourself methylation analysis. It was not based.
Yeah, because for sexual tumors and for most tumors, you do not have available databases. So we did it manually, or bioanalytics and genetics.
You know, I really like your paper. One thing that I think is missing is liquid biopsy. Wherever I am, I always advocate that we should be looking from early stages on whether some of the tumor cells are in the circulation. Did you ever try?
I haven't tried because these are most of the cases we have are consult cases from all over the world. So we have just one paraffin block for each case, and that's it.
And now we are here. Alberto,
Yeah, hi. So I guess I'll make a touch on one of the topics I'm going to talk in the afternoon. Yeah, we had several interesting discussions where you have unusual tumors that are studied very carefully with very fancy, expensive techniques, no? And then you end up with trying to estimate the prognosis. I think the fact that it's not often considered is how you are going to analyze the data, no? Because you do all these things and then you treat them with very simple statistics like the clustering analysis, which is not designed to classify individual cases. So if you're doing research in this area, it makes sense to apply, for example, neural networks. You put the same data and I'm sure the system will diagnose cases correctly or prognosticate cases to some degree of accuracy. No? So that would be one way to increase your severity. To apply, and usually you end up getting much better results than with regular statistics. The problem when one does a project, you talk to a statistician, most of these guys are not really familiar with the neural network technology. So they're not going to recommend doing that. Okay, that's on the technical aspect. The other feature, which I hope it doesn't offend anyone, is to think where pathologists are becoming bird watchers or clinicians. You know, bird watchers go on a trip, they take classes and they get very excited when they see this rare bird. But does that have any clinical significance? For example, in this example, you study very nicely. What are you going to do with the information if the light XL tumor is benign or malignant? I mean, the patient had surgery. What is going to happen? There's no way to predict for that individual patient what is going to happen. You tell them worst prognosis you're going to scare the patient. What are they going to do? There's no chemo.
If the patient is diagnosed with malignant light XL tumor, there is a very high probability that it will very quickly metastasize into retroperitoneal lymph node. So it is recommended for the surgeon to do right away the removal of retroperitoneal lymph node to prevent the further spread. So I think that a right assessment of the primary tumor is crucial for the patient.
I know, but then are there clinical trials showing that that really improves the survival of patients with light XL tumor? It's so rare that nobody has been able to do a study. No?
Yeah, but
so some of this information is used to do surgery or certain treatments that are really not well proven. No?
Yeah, but if you have light XL tumor, which we can see that it is definitely benign, the patient can be left with orchidectomy and that's it. So
no, you cannot say the tumor is definitely benign.
Yeah, I cannot. So that's why we are doing the research.
No, I know. But then the clinical significance is really determined. So I'm not knocking this down, but trying to put this in terms of clinical applicability, which in cases like this is very undetermined.
I mean, it's a tricky question how to deal with probabilities from studies and applying them for an individual patient. I mean, there's an ethical component to this as well, because we're dealing with probabilities, and when should you intervene to decrease the likelihood of severe disease progression? I don't have an answer. I'm just saying, I really see your point here, and it is well taken. And more research is needed, because still the predictive instruments are imperfect. So. Okay, thank you very much.
Thank you.
Anything else? We have quite a number of questions. And again, now the fourth presentation for this session by Christina. You are reasonably
This is my last. Okay. So my last case is case 47. Again, a renal mass. Probably you mentioned that I skipped from the morphologic diagnosis to tumors which are more clearly defined. So I will continue in this. So this case was a tumor of 84 years old gentleman. He underwent a partial resection of the kidney, and tumor was removed with the largest diameter about 4 centimeters. Here you can see the overview of the tumor. So again, we are back in a pink group of tumors. From the low magnification, you can see that there is some tubulopapillary arrangement of the tumor. Here you can see that in the periphery there is only atrophic parenchyma. The tumor is relatively sharply demarcated, but there is no encapsule. Again, more tubulary architecture. Here you can see tubulopapillary areas. Here you can see some compressed tubulary structures and in the periphery tubulopapillary appearance of the tumor. In some areas, the papillary and tubular structures are very compressed, so it looks like a pseudo-solid appearance of the tumor. And here you can see some detail of the cytology. So you can see that the tumor is composed from eosinophilic cells, homogeneous eosinophilic cells, with relatively small nuclei and with pseudostratification. Here you can appreciate the presence of papillas which are lined by these cells. In some parts of the tumor, you can see again the renal cytoma-like growing pattern of the tumor, so you can see edematous area, and on this edematous background you see nested architecture. However, the nuclei ATPs are higher than we are used in the renal cytoma. Here you can see detail of the cytology of cells. Again, homogeneous eosinophilic cytoplasm, mildly irregular nuclei, pseudostratification, and sometimes you can even see the nuclei. So this is all from morphology. So from morphology we cannot make the diagnosis, so we will turn to immunohistochemistry. So basic immunohistochemical panel, the tumor is completely negative for pancytokeratin, negative for PAX8. You can see the positive internal control in the renal parenchyma, and CD117 again is negative, again the beautiful internal control in mast cells. So from this immunohistochemistry, I'm going straightforward to my next immunostains which I employed. So melan A focally positive, HNB negative, and retain expression of FH and SDHB. So from this, when we summarize the morphology together with immunohistochemistry, I'm going to one special test, and this is fluorescence in situ hybridization. And I employed the enumeration probe for TFEB and the break-apart probe for TFEB, and it was with the positive result. For enumeration, so the tumor is TFEB amplified renal cell carcinoma. So, TFEB amplified renal cell carcinoma is a distinct entity in WHO classification 2022. It is included again in the molecularly defined entity. You should know that TFEB amplified renal cell carcinoma is included in umbrella cell TFEB altered renal cell carcinoma. TFEB altered renal cell carcinoma distinguishes two entities. It is TFEB rare renal cell carcinoma, which harbor fusion involving the gene encoding TFEB and usually MALAT1. And then there is second entity included in this label, and this is TFEB amplified renal cell carcinoma, which demonstrates amplification of TFEB gene. It is very important because the TFEB rare renal cell carcinoma is usually indolent, but the TFEB amplified renal cell carcinoma may have very aggressive behavior. In the first descriptions of these tumors, the tumor was described as tumors with a distinctive pattern. Usually they had biphasic morphologic pattern comprising nests of larger epithelioid cells and small cells clustered around basal membrane material. However, when more and more cases was published in the literature, we saw that the morphologic spectrum of this tumor is absolutely horrible. This is very wide and absolutely unpredictable. And this tumor may even mimic other renal neoplasms, so it is not easy to establish the diagnosis. Gold standard for the diagnosis is fluorescence in situ hybridization. For the FEB amplified renal cell carcinoma, there is a big problem because there is not precise diagnostic criteria for the FEB amplified renal cell carcinomas. There are authors there are tumors and authors which believe that only high-level amplification is the criterion for the diagnosis. However, even in literature you can find even authors and studies in which low level of amplification is enough for diagnosis. But if you compare the studies with low and high amplification cases, you will see that both these groups have the same aggressive behavior. So probably the criterion for the amplification may be established on low levels because both these groups probably has the same behavior. I was curious, so I made my own study on my own cases. So I searched for my cases of the FEB amplified renal cell carcinoma, and I was trying to compare the morphologic characteristic, immunohistochemical profile, and some basic clinical data. So in my series of 8 cases, the majority was males. The patients were usually older, and there was a very wide range of size. From the morphologic analysis, the predominant growth pattern was papillary or tubulopapillary. 2 cases had more tubulary arrangement, and 1 with cystic and 1 with more solid areas. What was important, all tumors contained cells with abundant granule cytoplasm, and only 3 cases had transition to more clear cell areas. So this is absolutely different than the original description of the TFEB amplified or TFEB altered renal cell carcinoma. From the immunohistochemical study of my cases, you can note that there was 4 cases which were completely negative for melanocytic markers. You can see that there was very important hyporeactivity for pancytokeratins, and very interesting was the reactivity for CT20, as the majority of our cases was positive, at least focally, for CT20. CT20 is the marker. The CT20 positivity is not normal in renal cell carcinoma. This is not fragment even. However, CT20 positivity was typically described in eosinophilic solid and cystic renal cell carcinoma. About 85% of eosinophilic solid and cystic renal cell carcinomas are positive for CT20. The positivity may be diffuse or only focal or only single cells. And a few years ago, this CT20 reactivity was even described in TFEB amplified renal cell carcinoma. I think this is very helpful in the routine praxis. From the normal marker GPN, the CT7 usually, the CT20 is usually positive only in few cells, so in only single cells are positive, but it is a good marker. And from normal markers, GPN and B was described as positive in the FEB altered renal cell carcinoma. However, in my study, or in my cohort, I noted only focal staining of GPN and B, which is in opposite to the FEB rearranged or translocated renal cell carcinoma, in which the GPN and B is typically diffusely positive. So differential diagnosis. So from the differential diagnosis, papillary renal cell carcinoma, NOS, oncocytic papillary renal cell carcinoma. So probably you know that about 20 years ago, Andreas and Michael described this entity as a subtype of papillary renal cell carcinoma. They described tumors with papillary architecture, eosinophilic cytoplasm. Some of these tumors even have had areas which resemble the renal oncocytoma-like pattern of growth. This entity or this subtype of renal cell carcinoma was included in WHO classification 2016 as a third subtype of papillary renal cell carcinoma. But there is one big problem, and this was that these tumors share some morphologic features together, but the immunoprofile, molecular genetic background, and clinical behavior is absolutely different. So after this study, which we made with Ondra, we decided that probably oncocytic papillary renal cell carcinoma is not a distinct entity, and probably the oncocytic papillary renal cell carcinoma is only a descriptive term which describes papillary tumors with oncocytic cytoplasm. And the last classification, the current classification of WHO, don't distinguish oncocytic papillary renal cell carcinoma anymore. So, and you saw that the majority of my cases fitted very well in this oncocytic papillary category. So probably oncocytic papillary renal cell carcinoma described in the past is only waste basket, and from this waste basket we are able to make diagnosis by molecular genetic testing. Other tumors in the differential diagnosis, alveolar renal cell carcinoma, and there is a big group of renal cell tumors in the differential diagnosis. These are pink tumors, so fumarate hydratase deficient renal cell carcinoma, SDH deficient renal cell carcinoma. Very helpful is the immunohistochemical staining. Eosinophilic solid and cystic renal cell carcinoma. To be honest, there is an overlapping morphology between the eosinophilic solid and cystic renal cell carcinoma and TFE-B amplified renal cell carcinoma in important part of cases. There is not only morphological overlap, but even immunohistochemical overlap, as both these entities has both entities have CD20 positivity. So for me, if I have a tumor which looks like eosinophilic solid and cystic renal cell carcinoma, first, I have to exclude the diagnosis of TFE-B amplified renal cell carcinoma with the fluorescent in situ hybridization testing. And when this tumor is negative for amplification, I'm going to call this tumor as eosinophilic solid and cystic renal cell carcinoma. And then there is a lot of different tumor in the eosinophilic group of renal tumors which we are not able to classify. So these all tumors are in the differential diagnosis. So take-home message: TFE-B amplified renal cell carcinoma may have morphology of papillary renal cell carcinoma with oncocytic feature. A positive staining for melanocytic markers is very important and has good sensitivity in TFE-B translocated or rare renal cell carcinoma, but in TFE-B amplified renal cell carcinoma, these tumors are fragmented completely negative for melanocytic markers. TFE-B altered renal cell carcinoma typically has low reactivity for cytokeratin and usually reactivity at least focal for CD20. And GPNMB is good marker for TFE-B altered renal cell carcinoma. However, you should know that in TFE-B translocated renal cell carcinoma, the staining is usually diffusely positive, but in the TFE-B amplified renal cell carcinoma, the staining may be only focal. Thank you very much.
I think it's been an amazing performance of four presentations in one session. Before coffee, any comments and questions pertaining to this case? I have a small question. Given the very broad histological spectrum of both TFE-B and TFE3 altered RCC, do you agree with the notion that, as I think I mentioned before, throw sort of broad spectrum keratin on it, and if it's extensively positive, you can forget about TFE-B and TFE3?
Not in all cases, to be honest.
Okay.
Yes, there are even cases of TFE-B amplified renal cell carcinoma which are diffusely positive for cytokeratin isolate.
Okay, good to know. If not, then I think we have this coffee break. Thank you very much for the speakers.
Good morning, everyone. Now we are in the last slide seminar session here. Interesting cases coming, quite a bit of soft tissue we see. And I'm gonna invite Dr. Švajdler to start the case. Number 48, please.
Yes. Thank you very much for kind invitation. This is my first ever talk in Rywlin seminar. Hopefully not the last. This is a case of 54-year-old man, and he presented with this ugly-looking, huge back of the neck mass involving C7 and TH1 vertebral and paravertebral tumor. It involved bony structures in addition to soft tissues, and we got some tiny piece of biopsies with a sarcoma, lymphoma, question marks, and this is actual microscopic aspect of the tumor. You can see it's infiltrating the tissue quite diffusely, solid looking, and the morphology of the cell is clearly undifferentiated. Okay, epithelial cells, nice vesicular thick nuclei with very prominent nuclei. In some parts, it showed this cohesive growth pattern, and the tumor had quite a lot of necrosis there. And as I said, bony structures were involved. This is diffuse infiltration, and this is again in high magnification cytology of the tumor cells, showing this epitheliate and almost rhabdoid-like appearance with somehow eccentrically located nuclei, and in parts having this dense rhabdoid-like appearance. And again, this is probably my last microscopic image. So with these only, I had no idea what it is, okay? We obviously have to perform a bunch of immunos, and we have performed quite a lot, and the tumor cells were not diffusely, but patchy at some areas, positive for cytokeratins. In some cells, a little bit accentuated and highlighting this rhabdoid-like appearance of the cells. And this was probably the only one spot for cytokeratin 7 positivity, quite a weak in T cells. And I performed, as I said, quite a lot of immunohistochemistry, including SMARCA4 immuno, and it showed loss of staining. If you are interpreting these kind of stains, you always have to have these background positivity in your internal controls, including capillaries and some stromal cells. So this is SMARCA4 deficient tumor. So my diagnosis was SMARCA4 deficient undifferentiated thoracic tumor. It's a high-grade malignancy affecting the thorax of adult patients, involving mediastinum, pulmonary hilum, lung, and/or pleura with or without chest wall invasion. Lung involvement is present in most cases, but may be overshadowed by mediastinal or extra pulmonary involvement. Morphologically, it shows this undifferentiated or rhabdoid phenotype, as I presented, and genetically, it shows big allelic inactivation of SMARCA4 gene. And importantly, these patients don't have germline mutations. This tumor was originally described as a sarcoma involving the lungs, pleura, or mediastinum in 2015 by a French group. And they presented 90 cases in quite a young population, 30 to 35 year old. With striking predominance in male patients, and most of them were smokers or ex-smokers. These authors also performed this clustering analysis based on gene expression profile, and these tumors clustered together with malignant rhabdoid tumors and small cell carcinoma of ovary hypercalcemic type, and clustered importantly in other cluster different from lung cancer. Quite interesting finding. Some Other papers followed in 2017, I believe. 12 cases and another 12 cases. Again, quite a young population, although in the second work it was the median age was a little bit higher, but again, the same pattern. Male patients, smokers, ex-smokers, and the prognosis, importantly, is very, very bad. So these patients survive only several months, 3 to 7 months. And there is another important work authored by Rywlin, so French group. This is the biggest paper out there, and they described 30 cases, again, quite a young populations, again, male patients, smokers or ex-smokers with very low median overall survival of 6 months. And again, they demonstrated SMARCA4 in majority of cases together with SMARCA2 protein loss of expression and SOX2 expression. They also described like variant patterns of this disease with this nice desmoplastic small round cell tumor pattern and myxoid background, or even this pattern with individual cells floating in mucin. They also summarized the genetical findings from previous works, and this is the table. Some of these tumors show, in addition to having SMARCA4 gene mutated, some other genes mutated, including TP53 in essentially in every case, and some other genes, including this KEAP1 gene, which is typically associated with smoking in pulmonary cancers. And this is the last work, 2020. I would like to show you again 22 cases with the same entity. And these authors also performed some genetic studies, immunohistochemical studies, and based on all of these, including previous works, although these previous authors call these tumors sarcomas, now it is believed that most of these cases represent, in fact, differentiated pulmonary non-small cell carcinomas. In this work, they even compared traditional non-small cell carcinomas with glandular differentiation, squamous differentiation, showing loss of SMARCA4 expression, because up to 5% of traditional cases may have loss of expression, but don't show this sarcoma-like morphology. And importantly, in this table, maybe you can read it with me, these sarcoma-like cases are bigger, present in younger patients, have bad prognosis compared to much worse prognosis compared to these traditionally glandular or squamous differentiated tumors. So, is it sarcoma or undifferentiated carcinoma? Based on all of these, now it's considered to be probably undifferentiated carcinoma in vast majority of cases. However, we still have up to 10% of cases which occur in never smokers and or don't involve the lung parenchyma at all. So there is still a possibility to have like second population of these patients with these tumors, and there's maybe something else in the pathogenesis. So this is another example from our files with this little bit myxoid or mucinous background, showing this discohesive, again, almost rhabdo-like morphology. Some cases show more spindle cell aspect and sclerosis, or sometimes even alveolar pattern and clear cell change. So what's the typical immunoprofile, and what you should use if you have suspicion for that? SMARCA4 together with SMARCA2 antibodies are probably the most useful. There is frequent SALT4 and SOX2 co-expression in these tumors. almost every case is P53 abnormal, and importantly, cytokeratins and claudin-4 epithelial markers are very frequently completely negative or only show very focal and weak staining. Importantly, synaptophysin staining may be positive, so this is pitfall because you can confuse it with, let's say, large cell neuroendocrine carcinoma. We also performed NGS analysis in the case, in addition to having SPARK4 mutation. In this case, we showed IDH2 and NRAS and KRAS and TP53 mutation. So in this patient, we probably have like the biotic target because there are IDH inhibitors available. And although one majority of these cases will have high tumor mutation burden, I don't know why our case showed low. And there were no targetable fusions. So this is very exceptional even to have like ALK or whatever translocation. And we also perform methylation profiling. I don't know whether you know this work. This is a classifier freely available at Dartmouth University pages. And this tumor was classified by this particular classifier as adenocarcinoma with lung origin. So this perfectly fits with that what it is, I think. And we have also performed some TTF staining, although it's quite weak and it was quite focal. It showed TTF1 positivity, so I believe it's real, the differentiated non-small cell carcinoma, adenocarcinoma. And if we go back to imaging, you can appreciate in serial sections that there is in the upper thoracic aperture involvement of the thoracic cavity, in addition to having this neck mass. And they also described it on this MRI that the tumor is in touch with the apex of the left lung, and this possible pulmonary involvement having this 4 centimeter nodule. I wasn't able to identify it on this imaging, but I'm not a radiologist. So what's the differential diagnosis? Many things, including lymphoma, melanoma, large cell carcinoma, nut carcinoma, mesothelioma, of course, rhabdoid tumors, germ cell tumors. In a female patient, especially when it's metastatic to the abdominal cavity, it is indistinguishable from small cell carcinoma, hypercalcemic tip of the ovary, large cell variant. Okay? And it is important to bear in mind that up to 5% of conventional non-small cell carcinomas will show loss of SPARK4 staining. Why is it important to identify these tumors? Because it's really important to tell it's probably undifferentiated carcinoma, to treat it like carcinoma, although the prognosis is still very, very bad. But nowadays, they are trying to develop inhibitors for cancers having these regulations in this SNF complex, including EZH2 inhibitors, and maybe immunotherapy will work for a proportion of these cases, but it's still hard to tell. The number of the cases is very, very low, and so far, I believe every patient died very soon, within few months after diagnosis. So thank you for listening, and
thank you. And any questions and comments? So it's between carcinoma and sarcoma, right? Yeah. Yes.
I just want to probe your view on this group of SPARK4 deficient malignancies. Are you a lumper or a splitter?
I'm probably a lumper. It's analogous, in my eyes, it's analogous to this SNF complex deficient, the differentiated carcinomas involving gynecological tract, GI tract, pancreas. The morphology is the same, the prognosis is very, very much the same, very bad tumors.
It looks like maybe we all have seen this, but we haven't recognized it because we thought it's gonna be like a poorly differentiated carcinoma.
This is a good point. If you have something which looks like this, sarcoma-like, undifferentiated with rhabdoid cells or not, and it's negative for cytokeratins, negative for essentially everything, you should think about this and do the stains. Okay, so SMARC-A4, SMARC-A2, SOX2, and SAL4.
And SAL4 may be meaning that it goes to stem cell direction,
Maybe.
in a way,
Yep.
because that's a stem cell marker. Next speaker, I'm gonna invite Dominguez.
Hello, everybody. Good morning. Well, I'm going to present a simple case for a change and for relaxation. This is case number 49. Okay. He's a young male, and the initial symptoms were pain in the right foot, not associated with trauma, and the symptoms increased in the last 10 weeks. On physical examination, 2 exophytic ulcerated lesions in the first and fourth toes, and no satellite lesions and no lymphadenopathy. And in this oblique projection of the right foot, there was a generalized decrease in ocean's density, as you can see here, and the lesion involved several bones of the foot, including the tarsal bones and the phalanges. There was a lytic lesion in the first toe, and another lytic lesion in the proximal phalanx of the third toe. And here you can see destruction or lytic lesions in the in many bones of the tarsus. Here's the histology. They look like rhabdoid cells or with ample cytoplasm, and a typical nuclei, which is again seen in this microphotograph. Was positive for vimentin, cytokeratin, and ER and CD31. Anyone was preserved, CD34 was negative. But this host D was completely positive. So, these are the positive stains. R, CD31, cytokeratin, CK7, vimentin. Anyone was preserved, and host B was positive. And all of the other ones were negative. we did electron microscopy. This electron microscopy is taken from the paraffin blocks. We use this all the time in Mexico. We have found that is as long as the tissue is well preserved and well fixed, you can make electron microscopy with good confidence. This was having this prominent nucleoli, ample cytoplasm, and it was filled with intermediate filaments. And in a higher power, you can see many of these violet palladi bodies. They were full of violet palladi bodies. So this was an endothelial differentiation by immunohistochemistry and electron microscopy. They were not rhabdoid in the sense that they were full of intermediate filaments, but no oral paranuclear filaments like a classical rhabdoid cell. So with that, we make this diagnosis of pseudomyogenic endothelioma. Historically, this entity was described since 1922 and 1992 by Mira. He found that there were cytokeratin positive young adults, and it involved multifocally distal extremities and frequently involved bone. At this time, he described 2 with metastasis, and one of them diagnosis. So it can be with malignant behavior. And they proposed the term, a variant of the pituitary sarcoma, probably myeloid variant or something like that. It was deeply seated and multifocal. In 2003, the group of the Mayo Clinic described similar lesions, predominantly epithelioid, and by immunohistochemistry were endothelial differentiation. They proposed the name epithelial sarcoma, like hemangioendothelioma. Finally, in 2011, Hornica Fletcher described 50 cases. It was young males in the extremities, and multiple plants could be affected. The dermis on the subcutaneous tissue, intramuscular and osseous lesions. And the recurrence was 50%, and one patient had a distant metastasis. I forgot to tell that this present patient, had suspicious nodules in the lung. So it could be a metastasizing lesion. They proposed the term pseudomyogenic hemangioendothelioma, and finally was accepted by the classification of the WHO. These are the cases of this particular article. cytolytic lesions, similar to ours, and is accepted actually with this name. These are the illustrations of the same paper. Later was described the fusion of the gene FOSB with several partners. SERPIN1 was one of them. And this is morphology. It's very similar to our case. There are cells with ample cytoplasm. And here's the differential diagnosis. There is frequently CD34 negative, CD31 positive, FLY1, ER, and FOSB are positive. Frequently, they are positive for cytokines, and anyone is preserved. The main differential diagnosis is with epithelioid hemangiothelioma, angiosarcoma, and epithelioid sarcoma. Here's an example of an epithelioid sarcoma. It's a central necrosis surrounded by epithelioid cells that can look like a granuloma. Here's another picture of the same entity. And the proximal type has the rhabdoid appearance. And is positive for cytokeratin and EMA. Epithelioid hemangiothelioma has this myxoid matrix with pseudoglandular structures, intracellular lumens, and stained for CD34. This is the cytology of the same lesion. As at least one endothelial marker can be CD31, CD34, or factor 8. Could be positive for any muscle marker, and in a fourth of the cases, there is an epithelial marker present. Epithelioid angiosarcoma is a pleomorphic lesion. It can be myxoid, it can have lumen, or may have papillary structures, and is positive for all endothelial markers, CD34 and CD31. Has all the malignancy signs in forms vascular channels, and the genetics is non-specific. In conclusion, the pseudomyogenic hemangiothelioma is a rare tumor, probably is underdiagnosed, probably is confused with some other tumors. It typically affects several planes. Could be skin, it could be subcutaneous tissue, or bone. The morphology resembles rhabdoid tumors. Has endothelial markers and characteristic FOSB can be done by immunohistochemistry or molecular studies. Because of this fusion, it's difficult to determine if wavy bodies are characteristic or not. because all cases studied by electron microscopy are very limited single reports. But in this case, we found this particular characteristic. And it has to be differentiated from other vascular tumors. Thank you very much.
Thank you, Uwe, for this very thorough presentation. One question, if there is anyone. I don't know if there are any questions, because it was very thorough. And beautiful case, by all means, very good example of that entity. So we're gonna move to, thank you, Uwe, so much. We're gonna move to Dr. Klubíčková next.
Good morning. Sorry for showing up here, but Natalia still can't make it here. So case 50. So this was an 81-year-old male who presented with a slowly growing mass in the skin and subcutis of his left arm. Clinically and radiographically, it was thought to be a calcified hematoma, and it was resected. Here is the X-ray where you can see this calcified mass on the arm. Let's go to histology. I guess already on low power you can see that the calcified matrix was histologically bone. Also here on low power you can appreciate the very thick fibrous pseudocapsule, and I'm sure the soft tissue pathologists in the room already know what this is. Also notice the multinodularity of the tumor, which is quite a characteristic feature. Actually, this case is pretty good example of this entity. Again, multinodular tumor with very prominent bone production. And again, this is different. I think this is a different slide from a different walk. Very thick fibrous pseudocapsule, which is very helpful. Diagnostic clue. Another section shows again multinodularity. And when we go on higher power, you can see quite monotonous proliferation of ovoid to spindle cells, and whenever we see, basically anywhere in pathology, monotonous proliferation, you can think that there might be, or you can expect that there might be, and very often there is, a single genetic event that causes this tumor, that the molecular background will not be complex as we see in many carcinomas or polymorphic tumors, polymorphic sarcomas and so on. Here, going in parts where there was the bone production, you can see bone in various stages of maturity, both mature bone, but also this quite immature osteoid production. It seems to be produced directly by the tumor cells. So kind of osteogenic differentiation here. I didn't make the picture, so I'm not always sure what was the message here, but I think this is supposed to illustrate myxoid areas, myxoid stroma areas, which alternate with more solid and hyalinized stroma parts. Again here, bone production and hyalinized stroma areas, quite cellular parts as well. And already in this medium magnification, you can notice in some areas mitotic activity. There was quite prominent mitotic activity, and if you couldn't appreciate it on the previous slide, I'm sure you could finally appreciate it here. Already at this, there was one more. Already in this one high power field, you can see 3 or 4 mitoses. There was also areas of necrosis, so those are the features of malignancy for this tumor, and in general, very often these features are used as a malignancy criterion in many other soft tissue tumors. So this is actually a case I was working on last year. It was a routine case from the faculty hospital, and kind of from the morphology, my differential diagnosis number 1 was ossifying fibromyxoid tumor. Second was ossifying fibromyxoid tumor, and third, very unlikely, but I thought it might be, if anything else than OFMT, this will be sclerosing epithelial fibrosarcoma, so I also did MAP4, but mostly I did immunohistochemical markers you would expect positive there, so S100. There should be desmin also. Cytokeratins are sometimes positive. And I was looking for immunohistochemical correlates of some of the fusions that you can encounter in ossifying fibromyxoid tumors. That means B-core and TFE3. But everything was negative. We did a targeted RNA panel and found EP300 B-core L1 fusion, which is a very rare fusion event in OFMT, but it has been already published as consistent with this diagnosis. And it kind of makes sense because both of these genes are involved in histone modification, which is a common feature of all the fusions, all the various fusion genes that you encounter in this entity. So the morphology and molecular findings were consistent with the diagnosis of malignant ossifying fibromyxoid tumor, OFMT. Follow-up, the resection was incomplete. They thought it's a calcified hematoma, so they just, kind of roughly excised it at the first operation, but there was a residual tumor, and it kept growing, so there was a radical resection performed, and adjuvant radiotherapy was added, and currently there's no evidence of tumor. That's like just a year has passed. So briefly, in general, about OFMT. So these tumors occur mostly in adults, and they typically involve circuitis of the extremities. But basically, any peripheral soft tissue site can be affected. And when I say peripheral soft tissue, it means you don't expect these tumors in retroperitoneum or mediastinum or these deep soft tissue structures, but mostly extremities, trunk, or occasionally head and neck as well. They are circuitous or deep soft tissues are affected usually, but you can see also very superficial cases involving the dermis, as we saw in our case. Our case was growing almost abutting the epidermis. The morphology is variable, but the typical morphological picture you see on low power, a multinodular, completely or partially encapsulated by thick fibers or fiber osseous capsule. Cytologically, the tumor is usually spindled or ovoid. Sometimes, especially the malignant examples, have a round cell phenotype. And the stroma, as the name implies, is fibrous or myxoid, or typically fibromyxoid. Typical cases have this trabecular arrangement, at least in some parts. If you want to see the typical morphology of these tumors, I recommend this beautiful paper by Dr. Mietinen and Fetch, the largest series I think published to date. But more or less common features, but still encountered in a significant percentage of cases, is extensive cartilaginous, lipomatous, or osteogenic differentiation, as we saw, osteosarcomatous differentiation, as we saw in our case. And there are cases described and molecularly confirmed with clear-cut epithelial differentiation. There are cases that look like adenocarcinoma, basically. They are positive for cytokeratins, they create glands. So this is just another fusion-associated sarcoma that can do crazy things. And don't look for a line of differentiation. It's just this kind of differentiation doesn't exist in normal human anatomy. So for clinical purposes, we try to classify these tumors into typical, atypical, or malignant categories. I'll get back to it on the next slide. And immunohistochemistry can be helpful, but is unreliable. Roughly half of cases are positive for S100 protein, at least focally, and the same applies for desmin. Less commonly, you can encounter expression of cytokeratins in some 10% of cases. The genetic background is very diverse, but most commonly you see fusions of a gene BHF1, with a smaller subset of cases having B-core fusions, or rarely other, such as B-core L1 is seen in our case. So overall, the molecular background overlaps to a great degree with the molecular background of endometrial stromal sarcomas, which is kind of interesting because in endometrial stromal sarcomas you very, very, very rarely encounter ossification, and the morphology is somewhat different. But the molecular background is both of the fusion genes are very often identical, and the common theme of these gene fusions is that they are involved in histone modification. So regarding malignant ossifying fibromyxoid tumor, the definition, we still use this definition from the paper by Dr. Volp and Weiss from 2008. So typical OFMT should have low nuclear grade and low cellularity and mitotic activity that doesn't exceed 2 mitosis per 50 high power fields, which is of course not. Everybody hates to count 50 high power fields, but that's how they defined it, and it seems to work pretty well. Then you have malignant OFMT, which should have high nuclear grade or high cellularity and mitotic activity, which goes over 2 mitosis per 50 high power fields, and whatever is in between is called atypical OFMT. And if you look at the outcome here, it seems to work pretty well. So the malignant OFMTs usually have thin or very often completely absent fibrous pseudocapsule. Our case was a good boy. It kept all the features, but very often in the malignant OFMTs you don't see the ossification and the fibrous pseudocapsule, and very often the malignant examples don't have S100 and desmin expression, and may show some unusual, other unusual morphological features such as just round cell, solid proliferation. And also, we've seen in the last years that the malignant OFMTs tend to be very often associated with BHF1 TFE3 fusions, or I would say the other way, BHF1 TFE3 fusions and these B-core fusions and this BHF1 fusion tend to be very often, the cases with this fusion tend to be very often malignant, much more than the other fusion subtypes. More than half of malignant cases recurs or metastasizes, so it's kind of important to classify it correctly. So here I'm going to briefly speak about our study on these tumors. We've collected 70 cases of OFMT with a molecular confirmation, and we are performing clinical pathological, molecular, and also methylation analysis of them. And we are focusing on unusual morphological patterns, less common fusions, and clinically aggressive cases. And mainly, I think the main question for us was actually these, as I mentioned, the cases with these B-core and TFE3 fusions. They are very often malignant. They have unusual morphology without ossification, without pseudocapsule, without the S100 desmin expression. And so we were actually asking, are these really OFMTs or are they something different? And that's why we included the methylation analysis, because that's something that can kind of help or provide an argument for or against classifying these tumors as OFMT. So this is our cohort. We have like an unusual number of malignant cases. This is not a normal population. We were asking our friends for cases, especially cases with TFE3 and B-core fusion, so this is not a normal population. This is significantly skewed for malignant examples. We found a bunch of novel fusions, but nobody really cares today. It's not anything interesting anymore, I think. And we did DNA methylation profiling of 37 cases, and then we analyzed that data using unsupervised hierarchical clustering and dimensionality reduction analysis. And we also did survival statistical analysis, where according to our data, the 5-year progression-free survival was significantly worse and statistically significantly worse in cases with the B-core fusion. There was also a trend for the TFE3 tumors to have a worse prognosis, but it wasn't statistically significant based on our data. I think it's just lack of data. There was also 5-fold increased risk for the histological diagnosis of malignant OFMT in these B-core and TFE3 fusions. And then this is the DNA methylation profiling. This is a little bit hard to read plot because these are these are the other soft tissue tumors. I don't remember which one is which, but we used some like morphological mimics. Osteosarcoma, also we include some bone tumors, osteosarcoma, sclerosing epithelial fibrosarcoma, and so on. And let's focus more on this cluster here, where we have OFMT here. So we kind of zoom in again. So here you can see the OFMTs with non-B-core fusions. All these dots are OFMTs with various gene fusions, but all of them, or none of them had B-core fusions. And there was also kind of interesting trend where the typical, the histologically benign looking cases tended to be here on the right side, and the more the more aggressive, the atypical and especially the malignant cases tended to be on the left side for whatever reason. I can explain that. But what was most interesting here for us, the OFMTs or so-called OFMTs with the B-core fusion clustered completely separately with high-grade endometrial stromosarcomas, which with the same fusion, because they can have the same fusion, or with, well, there was one case with B-core internal tandem duplication. Of course, this is just 3 cases were included here, so we are looking for more cases, and we are getting more cases from Italy for a better definition of this cluster. But it seems the B-core rearranged tumors, which have been classified until today as OFMT, are just different epigenetically and also histologically very often different. And they are also different from B-core sarcomas of soft tissues. You can have B-core sarcomas or B-core tumors fused with this fusion partner, and they occur in soft tissues and bone, especially in young boys. So they clustered separately from the B-core rearranged so-called OFMTs as well. So in summary, OFMTs are usually indolent tumors, but when you have increased cellularity, mitotic activity, and nuclear atypia, this may classify this tumor as a malignant or atypical OFMT. We use the Foltman-White's criteria as I showed. The pathogenic fusions in OFMT involve genes that code for histone-modifying proteins, and there can be many different fusions. Typically, there's a fusion with PHF1 gene, but more than 20 fusion partners have been described. The cases with a ZC3H7B core fusion are much more aggressive clinically. The same probably applies for PHF1 TFE3 rearranged OFMTs, and based on our DNA methylation analysis, the B-core OFM, or what was classified as OFMT with B-core fusions before, seems to make a separate or makes a separate cluster, and so there is a question whether this is a different entity or just a very distinct OFMT subtype. But the main message is these tumors are much more aggressive, so yeah, that might be clinically significant. Yeah, thank you for your attention.
Thank you, Michael. Again, very thorough presentation. I don't think we have time for questions.
I'm sorry, I just have one message. I'm sorry to interrupt.
Very small question.
Okay.
Those aggressive, males or females?
50-50. There is no strong predilection. Yeah. I'd just like to say, if anybody wants to see the lab with me, let's meet in the garage at 1 o'clock. Yeah, there's 2 hours for lunch, so we have plenty of time. So have lunch at 1 o'clock. We will meet in the garage. Just find me there, and we will go for a 30-minute tour of the lab. Yeah. Thank you.
Thanks, Michael. And now I'm going to invite Dr. Švajdler, please.
Hello again. So my next case is neuropathology. I don't know whether you have ever had neuropathology case on a MR meeting. Probably not. Yeah. Okay, but it will not be that neuropathology. Okay. This is a case of 30-year-old man who was admitted for persistent headache, and by CT and MRI imaging, tumor located in the left temporal hemisphere was found, measuring 7 centimeters, so quite big. The diagnosis is meningioma. Unfortunately, I don't have these scans from this first diagnosis because it's old case. And the tumor was resected and diagnosed by one of my former colleagues, I don't know the name, as a glioblastoma or gliosarcoma. However, after 19 years, the patient is still alive and is coming for another problem, with another headache problem. And MRI, this time revealed radiation-induced sensorineural meningioma. So I had a phone call from the boss of the neurosurgery department. Marian, please don't you want to look back at the case? We have a glioblastoma patient living for 19 years, and we have radiation-induced meningioma. We have never seen that because most of these glioblastoma patients don't evolve radiation-induced meningioma. They don't have time, they die. Yeah. So based on that, we reviewed the case. And this is the case. So it's somehow patternless, high-grade sarcoma, spindle cell, sprinkled with some giant, bizarre-looking cells. So, yeah, very malignant. Could it be glioblastoma? Yes, it could. Okay, so it's possible, and 20 years ago, why not? Again, pleomorphic spindle, maybe a little bit overweight, and sprinkled with these bizarre-looking giant cells. And immunohistochemistry performed days back showed a completely negative pattern, so nothing was positive. Okay, so they didn't have chance to do any other diagnosis. Maybe I will put some differential diagnostic options: metastatic sarcoma, dedifferentiated carcinoma, melanoma. So we have performed NGS studies and methylation profiling, and it came back with the diagnosis of primary intracranial sarcoma, there's one mutant. With this calibrated score 0.86, which is not like above cutoff. You see it's no match, but it's very high still, and it should be taken seriously. And in cases like these, you have to support the diagnosis with other means. So we have performed NGS. And it came back with missense mutation in the DICE1 gene, with TP53 mutation, the FGFR1 gene mutation. And I performed some additional stains. Almost everything was negative, but the tumor showed very focal. This is probably the only one spot positive for MyoD1 and diffuse PP53, and maybe a little bit of ATRX loss gene. So final diagnosis is obviously primary intracranial sarcoma. There's one mutant which is nucleated on the block in WHO classification, although we know that these tumor types exist for quite a long time. These are spindled or pleomorphic sarcomas. Basically always show high-grade sarcoma pattern. Some cases, or majority of cases, show very typical eosinophilic globules. I will show you this. Some cases have straightforward myogenic differentiation based on morphology and or immunohistochemistry with desmin actin. Sometimes myogenic positivity, but our case was myogenic negative and instead showed MyoD1 expression. And some cases show chondroid differentiation. In that case, it's indistinguishable from high-grade pulmonary blastoma. And by definition, these tumors show somatic or sometimes germline DICE1 gene mutation. So these are these nice eosinophilic globules. Majority of cases show these, and this is in fact very nice clue to the diagnosis. If I find something like this in your gliosarcoma case, it's probably not gliosarcoma, but this one. So this is the paper, they describe these globules. And some cases morphologically show this rhabdomyoblastic differentiation. So I was not able to find any cells like this in our case. The location of these tumors, as basically all intracranial sarcomas, is leptomeningeal or dural. And in contrast to other primary intracranial sarcomas, these tumors occur in small children. All other types occur more frequently in adult patients, with median age at presentation 6 years. And when I was preparing the talk, and in fact we have manuscript which is currently being revised, I was able to find only about 6 cases described in adult population so far. Clinically, these tumors are quite aggressive, but combined therapy, and this is only anecdotal information on very few patients. Combined therapy might have very good effect. In fact, our patient is prime example of that. Yeah, the tumor was gross totally resected. The patient received adjuvant chemo and radiation therapy, and he's alive. Pretty nice. In addition to having these DICER1 mutations, these malignant tumors in patients having especially DICER1 germline mutation show additional mutations including TP53 and some other, including MAPK pathway. Our patient has got these. Yeah, we show this FGFR gene mutation and TP53 mutation as well. The diagnosis is quite differential diagnosis is quite broad. In cases, especially when contrary differentiation is present, metastatic pleuropulmonary blastoma must be ruled out by clinical means, by radiology. Glioblastoma showing no or very limited glial differentiation may look like this, and some other possibilities are also in play. Anaplastic meningioma, NPNST. Sometimes these tumors show NPNST or more monotonous appearance, like synovial sarcoma, like atypical teratoid rhabdoid tumor, malignant solitary fibrous tumor, and of course primary or metastatic rhabdomyosarcoma or undifferentiated carcinomas or sarcomas. This very nice paper on DICER1 tumor predisposition syndrome. I really recommend to read this if you are interested, and you should, because it's a syndrome involving almost all body parts, yeah? And it's presenting with several benign lesions, several, let's say, borderline lesions, and several malignant lesions. And this is the table based like on morphology, and regarding the neuropathology, the sarcoma, macular ciliary body medulloepithelioma, pituitary blastomas are associated with the mutations, pineoblastomas, and small proportion of embryonal tumor with multi-layered rosettes. But pleuropulmonary blastoma in small children is a nice example. Gynecological tract, especially cervical rhabdomyosarcomas, are associated with this syndrome. And what Professor Jose told us about P10 hamartoma syndrome, essentially the same morphology in small children or young under 18 years of age. You might have this multinodular thyroid disease and a variety of cancers in thyroid gland. So if you got a child with multinodular thyroid disease, you should screen for P10 hamartoma and DICER1 syndrome. And this is just like another paper demonstrating that methylation profiling, how mighty tool it may be. In this paper, they had a bunch of cases in patients having this syndrome, and they were able just by doing like clustering based on methylation profiling to produce these clinical pathological groups with low-grade mesenchymal tumor DICER1, altered sarcoma DICER1, and primary intracranial sarcoma DICER. So this is something we can maybe use in future to tell the prognosis of the patients. And this is follow-up of our patient. Interestingly, we didn't find this germline mutation in a tumor tissue, but we found that there was a loss of chromosome 14 in the tumor tissue. So at the beginning, the tumor had B-allelic inactivation of this gene, and in tumor progression, it lost the chromosome with germline mutated allele. This is quite interesting finding in our case, and it can happen sometimes. And this is just a summary how mighty DNA methylation profiling may be in neuropathology. We are using it quite regularly, and this is my poster on this year's US Cup in Boston meeting. And we found it here in Pilsen to be useful in 78% of cases, I mean difficult cases. And you can see in this Sankey diagram, I'm not going into the details very much, how busy the diagram is. So changing the diagnosis, and sometimes it really matters for the patient. So right now, I've checked it yesterday, we have 762 cases with methylation profiles in this lab, and this includes, in the minority of cases, actually CNS cases, and majority are several sarcoma types, and we are playing with that and trying to develop a classifier for even for epithelial tumors, including kidney and some other stuff. So thank you very much.
Thank you, Dr. Švajdler, for very comprehensive presentation. I think in the interest of time, I'm gonna invite Dr. Franco Fedeli.
Good morning, thank you for the invitation. And the case that I want to present is a female of 14 years old that have a mass in the right thigh. And this is the mass, this is the MRA of the mass. This is possible to see in this MRA there is two types of signal. It's two different parts of this tumor. And here there's macroscopically that it's possible to see two different types of tumor here. And in histology, you can see just in this slide two different parts. In one part, in the lower part, is more diffuse spindle cell is possible after see after, and the other part, in the upper right part, there is more pelomorphic with this vessel with the collagen around the vessel. Here, the component with the more spindle, the cell are eosinophil sometimes, and there is collagen between the cell, indistinct border, cytoplasmic border, very few mitosis, and is all the same, all spindle. In another part, the cells are more pleomorphic, no mitosis, but very pleomorphic. There is many vessels, and around the vessel there is this collagen around the vessel. And here you can see the collagen around the vessel and this pleomorphic cell, polymorphic cell, but very few mitosis. It's possible to find mitosis, but very rarely. Here in the other part where the cells are more spindle and the cells are with the oval to round nucleoli, indistinct nucleoli, and here you can see the high magnification. And so, with summary, we are dealing with a tumor with the spindle cell, fasciculate architecture, pale scanned cytoplasm with indistinct cell border, and the nuclei are fusiform with the inconspicuous nucleoli, and the presence of pleomorphic multinuclear giant cell within the myxoid matrix. The activity mitotic is very low, perhaps it's less than 1 is okay. And another thing that is possible to see, that I remember, is lymphocyte inside of the tumor, and numerous vascular structure with hyaline walls and band of collagen. Focal area necrosis was seen, but in very small part of this tumor. And so differential diagnosis is very different part of the tumor, because in the spindle cell it's possible to think that it's a solitary fibrous tumor or cellular angiofibroma, mammary type, myofibroblastoma of spindle cell lipoma, fibrosarcoma, infantile fibrosarcoma-like, low-grade fibromyxoid sarcoma, and the low grade of malignant peripheral nerve sheath tumor, or in the giant cell is possible in differentiated polymorphic sarcoma, but there is no mitosis, and so it's not very good to fit into the diagnosis anyway. Immunohistochemical, the only positivity of this tumor is CD34, and so it's possible solitary fibrous tumor, but STAT6 was negative, and another positivity is S100. S100 and CD34. And so after this S100, we performed SOX10, but SOX10 was negative. And in summary, we have a tumor with S100, CD34 positive, and SOX10 negative. And I think with these three antibodies, it's possible to arrive at diagnosis. Because we perform pan-track, and the tumor is the immunohistochemically is pan-neurotropic tyrosine receptor kinase positive, and was confirmed by NGS, this translocation, and the diagnosis was NTRK rearranged spindle cell neoplasm, and is a new entity that was described in 2020 in WHO soft tissue tumor. This provisional category includes a group of rare soft tissue tumor defined by NTRK gene fusion, encompasses the wide spectrum of histology, and the clinical behavior is not well defined because ranging from benign to aggressive sarcoma. And the most part of this tumor affected children. The important thing is the co-expression of CD34 and S100 and negativity for SOX10. And here there is in another field CD34, S100 is positive, and pan-track positive. The histology that is very, very variable. It's possible to have infiltrative monotonous spindle cell morphology, solid pattern with stromal band that is possible to see in our cases, perivascular ring of keloid-like collagen, and is pleomorphic multinucleoid giant cell within a myxoid matrix, a pattern with donation resembling MPNST, and common pattern with Mayo-pericytoma-like architecture. In addition of CD34 and S100 positive, the tumor retains H3K27AME3 in contrast to many malignant peripheral nerve tumor, and the majority reactive with pan-track monoclonal antibody. A tumor with NTRK1 fusion show the most consistent and strong staining. NTRK fusion was described for the first time 30 years ago in colon cancer, and it's possible to find about 60 to 100% in infantile fibrosarcoma, that all cases are positive. In some cases, in secretory carcinoma of the breast and salivary gland, in congenital cellular mesoplastic nephroma, and in a quarter of cases in fully differentiated thyroid carcinoma, in spitzoid neoplasm, and pediatric glioma. In few cases, it's possible to find in lung adenocarcinoma, colorectal carcinoma, and papillary thyroid carcinoma. And NTRK antibodies is positive in this type of tumor, but is possible positive in rhabdomyosarcoma, in endothelial cell, normal endothelial cell, and in skeletal muscle cell. NTRK fusion form chimeric protein contain aberrant oncogenic receptor tyrosine kinase that are therapeutic target. And so this fusion is currently mandatory for systemic therapy, and one is the larotrectinib. The prognosis appeared to be related to the histology grade. Although many NTRK rearranged spindle cells are benign, are clinically benign, my case, I will not follow up on my cases, and firm criteria for malignancy have yet to be established. And so, we are dealing with a tumor with wide spectrum of histology, occur in the children, co-expression of CD34 and S100, and SOX10 negative, and the positivity with PANTRAC. And here there is the classification of 2020, there is a sort of review of the WHO classification as a very, very good presentation by Jason Hornick. Thank you.
Thank you, Franco. Now we have time for this one question. Yeah, needed maturation of one of these with a similar fusion. It said MPNST-like, which is kind of like a shady entity there in maturation now. Okay. But it's probably agrees very much with what you said.
Okay, thanks.
So let's then move to the next and last presentation, and I'll invite Dominguez, please.
Good morning again. This is going to be a very simple and short case, non-molecular case. I know we are at the end of this seminar, and it's been a pleasure to see you all here. And so I'll try to be brief. And I know everybody is tired now. So let's get started. Case number 53. He was admitted to my hospital in 2024 with intramuscular mass, well-developed intramuscular mass, which was myxoid. Myxoid is always a problem. That's a magnetic resonance. And somewhere the bone is, subjacent bone is involved. Thank you. And then that's brilliant with the isotopes. They did a marginal resection, and the tumor, the cut surface, was somewhere gelatinous, and the histology is like this. Few vessels, no enchypia, myxoid background. Some small capillaries, nothing else. It was CD34 positive, CD99 and was weak, active focal, and everything else was there. At the institute, some of the colleagues did even molecular study, which was negative and non-contributory. So the tumor was diagnosed as a low-grade sarcoma with myxoid background. And everything was ruled out. It says leiomyosarcoma. Solitary fibrous tissue, malignant peripheral nerve, and liposarcoma were ruled out. Then they took the bone lesion, and as you can see here, is the bone spicules are kind of funny, and the background, the matrix, is also myxoid. So this is a fiber of dysplasia with a funny looking stroke. And with the Masson stain was even more visible, the contrast. So the final diagnosis reconstructing the case was an intramuscular myxoma mixed with fibrous dysplasia of bone. So the presence of both lesions is consistent with Massa-Brown syndrome. This entity was described in 1926 by Henschen. It's like America. America was discovered by Christopher Columbus, and it's not called Colombia, it's called America. It's the same as this entity. Massa-Brown make a further characterization in another series of cases, and the name was on his honor. It's a rare disease. It's a kind of fibrous dysplasia with coexistent with the myxoid morphology. It is a very rare. The largest series is the European study, and in 1,400 patients, they only find 2% of coexistence. Essential for diagnosis is fibrous dysplasia. It can be mono or polystotic, coexisting with or without other symptoms of fibrous dysplasia. And it has to have intramuscular myxomas. The pathogenesis is due to activation of, the molecular alterations in the GNAS gene, which increases the cyclic AMP, which is a promoter of fibroblastic proliferation, and replaces the bone tissue by fibrosis and myxoid change. In soft tissue, it causes expansion of fibroblasts and more myxoid change. The fibrous dysplasia is more common in proximal bones, long bones, but bones can be also in the pelvis and tibia. Most cases, the intramuscular myxoma is adjacent to fibrous dysplasia. This is the European study, and with with myxoma with atypia can be recurrent with more frequent tumors. Associated with Massa-Brown syndrome are several tumors: osteosarcoma, fibrosarcoma, lymphoma, or the ovarian tumors, uterine tumors, and hemangioma in one study. And we have to consider with the myxoid change there are many syndromes. The LAMP syndrome with lentiginous myxoma, mycocutaneous myxomas, Bruni-Nevi. The name are Nevi, atrial myxomas, myxoid non-fibroma, and Fedeli. And the Carney syndrome, which has atrial myxomas, cutaneous, mammary, but also has lentiginous, Bruni-Nevi, endocrine disorder, and testicular tumors. And with that, concludes my presentation. Thank you very much.
Thank you for excellent presentation of a rare disease. And now we do have time for some comments or questions. So why does it happen that the tumor or two tumors come in the same place or close to the same place? And so you could think
could be coincidental because the part of the species could be mono or polystonic. And I think there are a few cases, by coincidence, they affect the same extremity. Probably the gene that affects the bone, this also affects the soft tissue around.
yes, so
no real explanation. I found no explanation for that.
Could be somatic mosaicism also possible.
Yeah.